RN is an 18-year-old female with a past medical history of Crohn's disease and sensory ganglionopathy, who presented with an acute flare of left rib and collarbone pain last week and admitted for IVIG initiation and further pain evaluation workup. Prior to this admission, RN was admitted to an on-site hospital twice in July for management of her Crohn's flare-up and started on Humira. Her first dose was on 7/15 and the second on 7/27. Steroids were also steroid, where she received significant improvement in her symptoms. Humira currently being held since August 10th and prednisone tapered, which has been initiated by the patient's outpatient GI doctor. No other immunomodulatory or suppressive therapy prior. She was diagnosed with IBD 1 year ago and had been having rectal bleeding for 4 years, but workup was delayed due to the workup and management of her sensory ganglionopathy, which is a rare neurological condition. RN began having pain in the left collarbone, left ribs, and left mid-back 7 days prior to this admission. The collarbone and back pain was not unusual, as this has been ongoing due to her sensory ganglionopathy, although the rib pain was new. During this admission, pain has persisted, worse with movement and lifting of the left arm above her head, also with deep breathing. She was febrile once on the 8th to 38.3, but no fever since. Denies cough, shortness of breath, or fevers at home prior to this admission. No sick contacts, no known TB exposures or recent travel or contact with any incarcerated individuals. She has a family dog for the past 13 years, and her sister has 2 guinea pigs, which she denies any close contact with. She recently saw 2 friends who traveled to Greece and Mexico. No history of recurrent lung infections or other infections. RN also had a pustular rash on her scalp, chest, and arms upon admission. Derm was consulted and thought to be scalp pustulosis and was started on topical clindamycin and benzoyl peroxide face wash, and the rash had resolved. ID has been consulted for further infectious workup. Allergies, she doesn't have any known medication, seasonal, or environmental allergies. Immunizations are up to date. Social history, RN lives at home with her mom, stepdad, and 2 sisters. Family history's been reviewed. Maternal grandmother with ulcerative colitis, and her father has cirrhosis. Her weight is 65.1 kilos. For vital signs, she's been normotensive to the 110s, the 70s. She's been afebrile, aside from that one isolated event that I mentioned earlier. Heart rate's been 70s to 100. Respirations have been in the teens to 20. Oxygen saturations have been 97 to 100% on room air. Eyes and O's this morning, she was positive 100. For pertinent labs, her CRP is uptrending today to 16.8, which is up from 8 5 days ago. ESR also uptrending today to 113. Prior to it was 67 5 days ago. CMP, she's hypokalemic to 3.5, hypoalbuminemia 2.9. CBC's been fairly unremarkable. Her UA was negative. For microbiology, there was a scalp skin culture done, a gram stain with moderate WBCs. The culture had rare mixed flora present. A quantiferin TB Gold was completed at the outside hospital, and it's been indeterminate. For imaging, she did have a 2-view chest x-ray, which recently, 2 days ago, showed a moderate left pleural effusion with consolidation in the left lung base retrocardiac region. A CT of the chest was done, which did not show any lung pathology or pulmonary embolism and no fractures. An MR of the spine and then of the whole body was completed, which revealed extensive soft tissue edema, joint, and pleural effusions that we already knew about on the left. On physical exam, generally, she appears well. She's engaged, talkative, alert, with definite some intermittent grimacing. HENT, Normocephalic, sclera is white, extraocular eye muscles are intact, and external ears are normal. Neck is supple with no adenopathy. For cardiac, she has a regular rate and rhythm, no murmurs, no gallops, strong pulses, and a cap refill of less than 2 seconds. For respiratory and chest, she's breathing comfortably, non-labored, good aeration, and clear lung fields bilaterally. For abdomen, it's soft, non-tender, non-distended, no no enlarged spleen or liver, and bowel sounds are normal in all 4 quadrants. For musculoskeletal system, she has that left collarbone and left lower rib tenderness upon light palpation, with some notable bilateral mild edema in the lower extremities. Skin has no rashes. My impression is that RN is an 18-year-old female with the history discussed above and persisting pain with an uptrending CRP and inflammatory markers and new onset of a left pleural effusion. Suspicion of infectious etiology is low given the absence of fever, how well appearing she is, and no respiratory symptoms. For the problem lists, we have health maintenance, left pleural effusion, ongoing inflammatory process, hypoalbuminemia, fluid overload, and pain. Differentials, infectious etiology. So no culture has been conducted yet on the left effusion. She's afebrile. The quant gold was conducted at the outside hospital. At that time, the chest x-ray was negative. Tuberculosis pleuritis is a possibility, although unlikely given the acute onset of the effusion. So we don't think that with, no symptoms, that's kind of contributing to her pain. But given the prior indeterminate result, we will consider. Inflammatory process is another secondary likely to her underlying sensory ganglionopathy. So the plan by systems for respiratory, we're going to continue current management with very close monitoring of her respiratory status given the pleural effusion. FENGI, continue the regular diet and bowel regimen. Also the prednisone taper, which she's at 5 milligrams daily. We're going to continue to hold the Humira. Continue her home pantoprazole, given that she's on the steroids, her home vitamin D. Monitor I's and O's very closely. She'll continue the scopolamine patch for the nausea, vomiting, which is not an active problem right now, and a daily BMP. For ID, we are going to obtain a T-spot, trend the fever curve, and monitor CRP inflammatory markers closely, and also we'll consider a pleurocentesis if suspicion for infectious etiology does persist. For neuro, we're going to continue with good pain management. She's on the Dilaudid PCA at 2.4 mics per kilo per dose with an 8-minute lockout and a max 1 hour of 40 mics per kilo per dose. Also on scheduled tramadol, 100 milligrams every 6 hours, and with frequent reassessments. Thank you.